Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about COVID-19 and public health responses. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box that you'll see at the bottom of your screen. Today's briefing has a sobering theme. Earlier this week, the United States officially surpassed 1 million COVID deaths, according to data collected by the Coronavirus Resource Center. And due to underreporting, we know that the number of fatalities is likely much higher than this. For today's briefing, each of our experts will discuss this morbid milestone through the lens of their expertise. Bloomberg School of Public Health. Beth Blauer is Associate Vice Provost for Public Sector Innovation at Johns Hopkins and the data lead for the Coronavirus Resource Center. Dr. Bill Moss is Executive Director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Dr. Brian Garibaldi is Director of the Johns Hopkins Biocontainment Unit and an Associate Professor at the Johns Hopkins School of Medicine. I'll now turn to each of our speakers for comments on the news that the US surpassed 1 million COVID deaths just a few days ago, and then we'll move to open Q&A. Crystal, first to you.
Thanks, Dr. Rutkow. Well, this 1 million death number is really shocking and frankly mind-boggling. As Dr. Rutkow said, we know that the U.S. actually has reached this tragic milestone some time ago, beyond the officially accounted for cases. The CDC actually estimated last fall that the burden of deaths being counted was about 1 in 1.3. So that means that hundreds of thousands of more people have died than are officially counted in our totals through the CRC. So even as we try to understand the true death toll that the pandemic has had so far, I want to make sure that we acknowledge also that the public health impact of these deaths is much more widespread than this official number. People who die from COVID have left behind family and friends, loved ones, very unfortunately, children without parents and grandparents to care for them, spouses and partners, and in some cases, parents who have to go on without their children. So the toll goes beyond the deaths themselves. It is a toll on the mental and physical health of those left behind, and it's very difficult to quantify and often goes unacknowledged. So this, along with the large numbers of people who are currently living with long COVID symptoms, it really means that the pandemic will unfortunately be felt by people, individuals, and societally, and reflected in our public health data for a long time to come. But this isn't over yet either. We are now in the midst of a surge here in the US. It's the uptick in cases is not being officially counted as sharply as what happened back in the winter months with the original COVID variant. But we are seeing, especially in the northeastern parts of the US, that states and counties are now trending into the high levels, according to CDC's community COVID metrics. And so it's still important to be actively vigilant about preventing infection, and we are doing our best to capture the cases and deaths as we move forward. I think with that, I'll take a pause and pass it back over to you, Lainie.
Thanks so much, Crystal. Beth, as our data lead for the Coronavirus Resource Center, can you comment on the recent milestone of 1 million COVID deaths in the United States?
Yeah, I think that, Lainie, I go back to where we were in 2020. And if you would have talked to us about a 1 million death mark in this country, I think it would have been unfathomable, and it still feels quite unfathomable today. But as Crystal said, we know that we have surpassed this number probably some time ago here in the United States. And it is a somber reminder that we are still losing Americans every single day to COVID. This is still very present in our communities. But we are now flying very blind with a very limited understanding of where the disease is, what communities are being disproportionately impacted. And that's because we've seen a real shift in the way that our policymakers are thinking about COVID and the way that they track COVID. And so we continue to have many states that are clawing back their data collections, that are relying on some more familiar and well-worn paths in public health, that are taking down their resources and their state dashboards. And that is kind of a call to attention to us, those people like me focused on the intersection of this data and public policy, about what have we learned from COVID? And what are the lessons that we're going to be taking out of the last 2.5 years of tracking, where at times we were able to be very precise about where we were sending out testing resources and vaccination communications and resources. As we start to scale up our data and start to lose sight of the kind of more granular geographic impacts that this disease is having, we are going to lose the ability to be precise in the way that we think about intervention, the way that we're targeting mitigation. And I think that that's going to continue to exacerbate the sort of fatigue that we're feeling publicly around COVID and around the measures that we know that will keep our families safe. And so it's something that we're tracking very closely. We've been highlighting this through the Pandemic Data Initiative around the real implications of not having a national strategy around tracking and sharing information around COVID. And I think those problems will persist, and they are going to really be at the foundation of what I hope is some reforms in the public health field overall.
Thanks, Beth. Bill, as our vaccinology lead at the CRC, can you speak to the recent 1 million US COVID deaths from your perspective?
Yes, thank you, Lainie. This is such a tragic milestone, but it's made even more tragic by the fact that many of these deaths could have been prevented through vaccination. I also want to highlight that around the time the United States reached this milestone of recorded 1 million deaths, the World Health Organization has estimated that globally the pandemic has resulted in nearly 15 million excess deaths in 2020 and 2021. Now, certainly not all of these deaths, both here in the United States and globally, could be prevented through vaccination. We know the vaccines are not 100% effective, even against severe disease and death, particularly in the elderly and an immunocompromised person. But a substantial proportion of these deaths could have been prevented had we achieved higher vaccination rates more quickly. There have been two recent analyses, Lainie, attempting to estimate, and it needs to be an estimation, the number of deaths due to COVID-19 here in the United States that could have been prevented through vaccination. A recent analysis by the Kaiser Family Foundation estimated that about 60% of all COVID-19 related deaths in the United States since June 2021 could have been prevented through vaccination with just the two doses alone. So not with a third dose, a booster dose. This is an estimated 234,000 deaths. Now we know, particularly during the Omicron wave in December and January and into February, that a third dose, a booster dose, was offered significant protection against severe disease as well. So this was just with that primary series of two doses. There was also a recent analysis, Lainie, from our colleagues at Brown University and Microsoft AI Health that estimated nearly 319,000 COVID deaths could have been averted had adults gotten had we achieved higher vaccination coverage since the start of the pandemic through the end of April. And so what they estimated is that after vaccines became available, 641,000 people approximately died. And so 318,000 is about, or 19,000 is about half of the deaths since vaccines became available are predicted in this model to have been preventable. And again, I think this just further highlights the tragedy of this milestone. And there's a lot of heterogeneity across the states, across the United States, where some states, more than half of deaths were estimated to be preventable. So I think this just highlights the fact that we need to continue to do a better job in increasing vaccine coverage. There are still communities and still vulnerable individuals who not only need to get the first 2 doses, but need to get a third dose, and perhaps, and many even a fourth dose, those who are most vulnerable. And my little quip, Lainie, that'll end is we cannot afford to become numb to the numbers, and we need to continue to be vigilant. And one of our best tools is vaccination.
Thanks, Bill. Can count on you for a new Friday quip. Cannot be numb to the numbers. Going to turn to Brian now. Brian, can you give us your perspective on this recent milestone from your clinical and therapeutic expertise?
Sure. Well, first I wanted to just express my sincerest condolences to the family and friends of those who have been lost to COVID. You know, we've all obviously been impacted by the pandemic, but none more so than those who have experienced the death of a loved one. And I think that's really important to take time and reflect on that. You know, I think Bill raised a really important point that I wanted to mention, which is the fact that we have to be really careful not to normalize death from what is now in many cases a preventable disease. You know, before COVID, we used to take it as given that 30 to 50,000 people a year would die from influenza. And we've seen that with, you know, a careful attention to data and wearing masks and appropriate social distancing and with vaccines, we can, you know, largely eliminate death from respiratory viral pathogens if we recognize where they are and we act according to the data. And so, I think it's really important that we don't allow this to become the new normal, where we are allowing a preventable disease to kill hundreds, if not thousands of people every day. You know, it's an important time to reflect on what we've learned over the last couple of years and to really keep those lessons in mind as we head into yet another surge. The first thing I would say is that masks work. We know that they work, and despite misinformation about how masks are just facial coverings, I mean, that we know that they prevent disease, and we know that they can, you know, tamp down the spread and save lives. And so I would really urge people to consider their own circumstances, to know what's going on in their community, and to really consider wearing a mask, particularly at indoor gatherings, if you're in an area where cases are on the rise. And again, I think we've all said this before, it's not just about you, it's about those around you. And there are still many people who have not been vaccinated, and there are many people who have an underlying condition, particularly with their immune system, that prevents them from mounting an effective response to vaccines, and they're still at a very high risk of severe disease or death. Vaccines work. You know, for those who remain unvaccinated, I'm really worried that many of them have made their decision not to get vaccinated based on poor information or misinformation. And we need to do a better job about getting reliable facts into the hands of people so that they can make informed decisions. And in many cases, I imagine if we were able to get the right information to these individuals who are unvaccinated, they would make the choice to become vaccinated. And if you're vaccinated and not boosted yet, why not? Now is the time to do it as we head into another surge. We know that it will restore some protection against symptomatic disease, but is still very, very effective at preventing severe disease, hospitalization, and death. If you test positive, we now have effective treatments, particularly for outpatients. We have oral therapies, we have monoclonal antibody therapies that work and that reduce the risk of hospitalization in some cases by more than 90%. And then once you become hospitalized, we do have some therapies now that reduce your chances of going to the ICU. But in order to access those therapies, you need to get tested, and you need to be able to get the right information. I have a friend who was diagnosed this past week in New York with COVID, and their primary care provider prescribed ivermectin, Plaquenil, prednisone, and doxycycline. Therapies that we know for outpatients do not work and have been studied in very large trials. And so, it's just unconscionable to me right now in 2022 that a healthcare provider would prescribe those therapies for someone with COVID who is at high risk, when we know that there are effective therapies that would give you a better chance at getting through this illness. We need to also remember and pay attention to the disparities that have been highlighted by COVID, not just in our healthcare system, but in society in general. And I think we need to pay particular attention to the disproportionate burden that individuals and underrepresented minority groups have borne during COVID. And we need to work to address those issues now during the pandemic, but we can't just make this something that we only think about during COVID. I mentioned this before when we were talking about misinformation, but we need to work to restore our faith and trust in medical institutions and healthcare agencies like the CDC and the WHO. And that's on us as healthcare providers to do a better job at disseminating information in a way that everyone can understand. And it's not just enough to talk about misinformation. We need to actively combat it and recognize it as the threat that it is, not just to public health, but to the very nature of our society. And I think the last thing I would say is that we need to recognize that climate change is a public health issue. As we're thinking about this current pandemic, this is the third time in the last 20 years that there's a novel coronavirus that's been spread from person to person. Each one is worse than the one before. And this is just a general reminder and a warning that zoonotic diseases are on the rise as climate change has changed the way that we interact with animals in our environment. And the interconnectedness of our world now means that we need to step up our surveillance, not just in the United States, but everywhere. Many of our viewers are probably following what's been going on with monkeypox cases in Europe and in North America. And this is just another example of a zoonotic disease that we need to be aware of, and we need to really ramp up our surveillance systems. We need to pre-position medical countermeasures for the next infectious disease threats. We need to anticipate what they are. We need to continue to work on not just vaccines for COVID, but vaccines for other diseases that are possibly going to make the jump from animals to humans. And we really need to enhance our ability to bring testing online quickly. So I think I'll stop there, Lainie.
Thanks so much, Brian. I'm going to stay with you for our first question. Several questions coming in about Paxlovid and the so-called rebound that folks are seeing just after day 5. Can you speak to that and what you're seeing clinically?
Yeah, so this is, I think we talked about this the last time that we were together. There is some data suggesting that viral loads can rebound after the 5-day course of Paxlovid. There isn't clear data yet that those rebounding in viral loads in a small subset of patients is the cause of these recurrent symptoms. What I would say is that this is a small percentage of people, as best we can tell. But if you do go on Paxlovid, you were feeling better and you start feeling worse, that's definitely an opportunity to talk to your healthcare provider to make sure that there aren't other things that you need to do in order to make sure that you've cleared the infection. I would say that particularly for people who might have an underlying immune system condition. But the drug is very effective at preventing hospitalizations. We've seen that in the clinical trials, and we're seeing that as it plays out in the real world. But we don't yet have a clear sense of why this is happening to some people who do have a rebound in symptoms after they finish their course.
Thanks, Brian. Crystal, question for you. Can you speak to the variants or the subvariants that we're seeing right now, especially BA4, BA5, or any others that you think the public should be aware of?
Yeah, that's a great question. So in the US, the most significant subvariant of Omicron right now is BA2.12.1, and that is currently what appears to be causing the significant surge that we're seeing in the northeast of the US. We are also seeing other sublineages of Omicron, BA4 and BA5 in particular, which are causing a surge in South Africa and some other African countries in particular. Both of these subvariants have been detected in countries throughout the world. And these are the most significant ones that are being tracked right now. They all have some additional immune escape beyond the original Omicron variant, the BA1 variant. They don't appear to be causing much more serious illness in people who get these sublineages, but we are seeing reinfections after people have been infected with the original BA.1. So these are all things to watch. We are also on the lookout for other variants that might emerge that are not related to Omicron. But these are the ones that are the most significant right now and are causing the surges that we're seeing both in the US and in some regions globally.
Thanks, Crystal. Beth, question for you about at-home testing and what has that meant for testing data more generally?
So at-home testing as a threshold issue is a huge benefit to public health. When people have easy, accessible mechanisms in which they can access testing, then that allows them the ability to test before they're going into crowded situations or social gatherings. And we're trying to encourage this as a behavior. The problem with the testing infrastructure in terms of the data is that data is not captured anywhere. We are not doing a good job of capturing at-home tests or antigen testing across the board. Most of the antigen testing that we see in our formal reporting is from congregate care settings or places that have institutionalized data reporting. And so it begs a larger question is that if we're trying to encourage the use of at-home tests and antigen testing, why have we not made the shift in our testing infrastructure to be able to capture that data? And what is happening is a dilution in our capacity to do surveillance of COVID before the kind of worst outcomes of hospitalization and death. Because our case data is now diluted with the fact that many people are figuring out that they have COVID using at-home tests and not reporting either to primary care where that can be captured or through any of the applications that accompany some of those tests. And so as we think about long-term reforms to the public health system, we really need to think about how we can do a better job at capturing this information. And we've seen in some of the places around the world that have more socialized approaches to medicine, that they have a more structured way of capturing surveillance that's happening in the home. That's just not the case here in the United States.
Thanks, Beth. Bill, several questions coming in for you about what the next several months or the second half of this calendar year may look like relative to vaccines. We're hearing things about the potential for a combined flu COVID vaccine, for a fourth, or for some folks, a fifth shot. What do you think is likely coming down the pike?
Yeah, so thanks, Lainie. It is a really important question. A lot of people thinking about this, but I just want to highlight there are still a lot of unknowns around this, so it is quite hard to predict. We do know that the FDA Advisory Committee on vaccines will be meeting at the end of June and kind of hopefully laying out a plan for what the fall and winter will look like. There are a couple of, and it will also very much depend on what the virus does, as Crystal outlined, whether we'll continue to see Omicron-related lineages, or whether we'll see something completely different, and that will change the ball game for vaccines going forward. There has been a lot of discussion and work on Omicron-specific vaccines, but there is some data that suggests that an individual who's gotten 3 doses of one of the current mRNA vaccines will have a very similar neutralizing antibody response to the Omicron variant compared to someone who's gotten 2 doses of the regular mRNA vaccine and then an Omicron specific. So I say that because right now it's not a slam dunk that an Omicron specific vaccine will be the answer going forward, but that certainly requires further investigation. There is a lot of discussion about whether there could be a combined influenza COVID-19 vaccine that could potentially be administered annually in the fall if this really becomes a winter virus. I have some hope for the nasal vaccines as being perhaps inducing more what we call mucosal immunity, perhaps offering better protection against infection, and that could also serve as an additional dose. So I do, and my bet would be that we will be revaccinating many folks here in the United States come the fall. Many folks should be getting, as Brian pointed out, even a fourth dose now, particularly those who are most vulnerable, the elderly. And I think in those groups, we probably should be thinking of this as at least a 3-dose primary series and then boosters on top of that. But again, just to summarize, there's still a lot of open questions about what the fall and winter are going to look like. But we do need to begin planning now. And there are a number of different scenarios that could get played out.
Thanks, Bill. Crystal, a question for you about mask mandates. So we're now at a point where there are very few mask mandates, and at least a sense that there's hesitation to reinstate them. Do you think that we're likely to see a return of mask mandates? What would your recommendation be?
Yeah, I think we'll have to wait to see the outcome of the Justice Department's push to reinstate masking for public transportation. So we will have to wait on that official guidance. But I also know that the CDC guidance does include recommendations for masking when a community reaches that threshold of high community COVID burden. And as I said, particularly in the Northeast, some in the Great Lakes area, there are counties that are reaching that level now from this surge. So in a place where hospitalizations are going up and have reached a level at which that you are in this high state, then wearing masks indoors when you're in public, particularly in crowded spaces, is really important. So I think we will see recommendations for masking, especially as we go further into this surge. But we'll have to, it is kind of individual on the state right now, and or a company or organization to whether they're actually requiring masks or not. But I do think when we have that high of community COVID, masking is a really good idea.
Thanks, Crystal. And Brian, I'm going to send today's final question to you. What are you seeing with monoclonal antibodies in the current surge? Effective or less so?
Yeah, so I would say that we still have at least one that seems to be effective against the different Omicron variants. We have been using a lot of the oral antiviral therapies, in part because we know that getting these therapies quickly is associated with better effectiveness. So, for example, I got called by a patient last night at 6 o'clock that they had just tested positive, and I knew that I could get an oral antiviral to them within the next 2 hours. But I was uncertain how quickly I'd be able to get them an infusion of a monoclonal antibody heading into a weekend. So I think we still have them, they're available, but now that we have an oral antiviral for many patients, that is probably a faster and an easier option. And at least in the clinical trials, the effectiveness has been very similar. And so far, we have not seen any clear evidence of resistance to the oral antivirals with the different subvariants. So I think we have two very good options for many patients. The oral therapy is probably first line, and in certain circumstances, or if someone's taking other medications that would interact with the oral therapies, the monoclonals, there still are some that are effective.
Thanks, Brian. And with that, I'm going to close out today's briefing. I'd like to thank Crystal Watson, Beth Blauer, Bill Moss, and Brian Garibaldi for joining me today. Give a big thank you to everyone who joined us, and especially to those who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. On behalf of our team, we extend our condolences to everyone who has lost someone to COVID. Until next time, thanks and stay safe.